Good morning, and welcome to this week's episode of Ask Dr. Murphy. I hope everyone is doing well today. My name is Katie Berg. I'm a research study coordinator with the Havey Institute, and I'll be leading today's discussion. I'd like to welcome and introduce Dr. Robert Murphy. Dr. Murphy, how are you this morning?
Doing very well. Thank you, Katie.
Dr. Robert Murphy is the executive director of the Havey Institute for Global Health and the John Philip Fair Professor of Infectious Diseases here at Northwestern's Feinberg School of Medicine. He answers your COVID, infectious disease, and public health questions each week here on the Havey Institute for Global Health's Facebook page. Today, Dr. Murphy will be spending a large portion addressing viewer-submitted questions, as well as the latest headlines and our lone U.S. COVID statistic. Please feel free to send any questions, comments, or suggested topics below or at any of our social media, Facebook at NU Institute for Global Health, or by email at globalhealthinstitute@northwestern.edu. Starting with our lone COVID statistic. Average COVID deaths per day in the last reported week were 61. In the same week in 2023, we saw 200. Dr. Murphy, your reactions to those numbers and the state of COVID in the country.
Well, winding down, the summer bump is basically over. The wastewater data, which is a little better indicator of how much COVID is floating around in the community, is at low levels now in most places. There's a new variant, XCC, that's out, but it's just easier to transmit variant. So the summer wave is over. So now what happened? This will stay down. The mortality rate will continue to go down, probably into like the 20s. And then we'll have the winter wave along with flu. And that will start like in November, December, and then be big in January and February and start going down again in March, just like it does every year. So there's these patterns and we can follow them, and that's what we can expect.
Mm-hmm. Now, we received a multi-part question from a viewer, so I'm going to break it up a little bit here. But first, can you clarify and re-explain the information that came out concerning cardiovascular disease and COVID? We talked about that study last week. Does it seem like almost everyone should be, talking to their doctor about this, maybe getting a checkup every once in a while if they've had COVID?
Yeah, this information has really gotten a lot of attention. In a study last week that we talked about, we found that that after you have COVID, you have 2 to 3 times the risk of having a cardiovascular event in adults after COVID infection. 2 times just for infection and 3 times for severe infection, which includes hospitalization. But the data was from before January 2021. So, how relevant is that today? So that's the, original virus, even before Delta. So we don't know, but that was really kind of, it shouldn't really surprise us because we knew cardiovascular disease was one of the risk factors for COVID. And so now it's a little bit clearer now that we have data from these bigger studies. So, and then there's been like more studies. People are following this now. So in the Omicron wave, we found that the patients with cardiovascular events were younger than in the first wave by a few years, and that the cardiovascular events during hospitalization, the mortality rate in the Omicron wave was significantly lower than the first wave. It was only like 27% versus 48%. So people have developed, more immunity. Who knows? It's impacting it somehow. And Omicron, of course, is a less virulent virus. And so the most recent data shows that measuring both COVID and cardiac deaths from 2023, just last year, COVID-19 was the underlying cause of death in 1.6% of people, 76,000 of all deaths in 2023. And that decreased from 5.7% or 186,000 deaths in 2022. So you can see there's this very steep drop off in the mortality rate. And the deaths from heart disease also decreased in 2023. And you can't really correlate the two, but it is really just kind of interesting that the death rates from both of those have gone down together. But that doesn't mean they're linked. There's so many reasons why a person can have a cardiovascular event. I mean, if they don't get checkups, if they don't treat their hypertension and the other risk factors, so if they don't see their doctor, all that comes into play. So we don't know where COVID fits in there.
Mhm.
And then there's another paper that looks specifically at the Delta variant. Remember that came in late 2021 and early 2022. And they found that there was an excess burden of cardiac events, but they were lower among the fully vaccinated. This is where the vaccines come in. So the fully vaccinated did much better. And they had even less hospitalizations and less events than the unvaccinated. And so it seems that you can look at these risks as the risk is highest if you have COVID and you've never been vaccinated, and then it's lower if you have been vaccinated, and then it's lower still if you've been vaccinated and boosted. So the more immunity you have, not only the fewer events that you're having, but you're having less serious events. So it's really fascinating data how this link with cardiovascular disease. I think we'll learn a lot more in the future about this because, of course, this is incredibly important information that needs to really be dissected and studied further.
Mhm. The viewer was also wondering if some of these heart events were more common in men than women. I do understand that it's really difficult to get some of those demographics from large data sets because of, patient identifying information. But has there been any evidence that
Well,
based on some of the
men have
sex?
more risk to begin with. So whether, and then fewer men took the vaccine. I mean, there's all sorts of interactions, but men generally have higher rates.
Very interesting. Now, looking at a different age group still revolving around COVID, there's some very big research that came out regarding young people and the incidence of type 2 diabetes following COVID infection. Can you please break down that research for us?
Yeah, this was a very fascinating and kind of disturbing paper. So diabetes, very common, causes a lot of problems, a lot of more mortality and morbidity in the world, in the United States in particular. There's two types of diabetes, type 1 and type 2. Type 1 are the type that occurs in very young people, and they're unable to make insulin. And that's why they're treated with insulin, because they have to, people that are taking insulin have type 1. Type 2 is a very different kind of disease, really, in that they have plenty of insulin. Matter of fact, they have too much insulin, but they can't use the insulin. The receptor that lets the insulin work, let the glucose in, there's not enough of them, and the body, so the glucose gets too high. That's a very very rough way of looking at it, but that's the main difference. One needs insulin, one doesn't, needs other kinds of therapies. So anyway, so this is the kind of information you get from these huge databases. So this is a database, electronic database from 613,000 patients aged 10 to 19 years old. 306,000 had COVID, and another 306,000 had other respiratory infection, but did not have documented COVID. The mean age was about 15 years of age, about half girls and boys, and 57% were white, the rest non-white. And the risk of type 2 diabetes was significantly higher from the day of infection to 1, 3, and 6 months after a COVID diagnosis than any other respiratory infection. And this risk increase was over 50% at all three time points, 1, 3, and 6 months. And boys and girls had the same risk. This is diabetes now, not heart disease. Now, diabetes is a risk for heart disease, but that's another story. Similar results were seen in patients who were overweight or obese, which was even a higher risk, about 100% increase, or like twice as many as expected, and in those who had serious disease. So young people typically didn't get serious disease. Remember, it was mostly older people, but the younger people that had serious disease had 2 to 3 times the risk of getting type 2 diabetes. So why is this important? Well, I mean, this is another risk for getting diabetes, which, the estimated cost of diabetes in the United States to treat everybody with diabetes was $412 billion. And that includes direct costs and the cost of disability, people unable to work or whatever, they're too sick. So that it's a gigantic medical expense. And if we can do anything to prevent that, it would be good. And it also just tells you that if this really holds up, because now a lot of people are looking at this factor, it'll be studied in multiple different cohorts. If this is really true, the whole thing about vaccination being reserved for older people with underlying heart disease kind of goes out the window. And that you should really be vaccinating younger people so they don't get exposed to COVID, so they don't get diabetes and they don't have cardiovascular events. I mean, it's just it changes things, because when you give a young person a chronic disease, that imagine they live with that chronic disease their entire life. So it's very troubling, and of course it's much more difficult, much easier to just prevent the whole thing.
Mhm. And of course, like you mentioned, one of the most important factors in the scientific method is replication of these studies. So we will,
Yeah.
of course, be looking out for further information, more studies on this subject.
Oh, that's an incredibly important point. So now this has been reported. So now other groups will look at it. The Europeans have a great database. There's other databases in Australia and other countries, and other groups within the United States can look at their databases and verify if they saw the same thing. If they don't see the same thing, how do we explain this? So more work has to be done. But this is a very, very unfortunate observation at this point.
Very much so. And like I said, we will keep our eyes on it. But
Mhm.
moving on to another submitted question, along with one of our biggest headlines over the past few months, our viewer asks, seems like the avian flu is beginning to be quite worrisome. We can't vaccinate the birds, but if workers are getting infected from the cows, why don't we look into vaccinating them? Are dairy herds cold like we see with the poultry? And also, can you just update us on any further human cases of H5N1?
Yeah, so there's more cases reported from California. There's one in Illinois that's under investigation right now. The total number of human cases is about 20. Nobody's even been hospitalized. We keep saying, oh, avian flu in humans is so bad. But so far, it's been a very mild type flu in these 20 people. But let's just say we got to be careful, because in other outbreaks in humans working with birds, mostly in Asia, the mortality rate was up to 50%. So something different is going on here. So we don't know. It's the same type of virus. And regarding vaccinating animals, cows get vaccinated, but it's not killing the cows. The mortality rate in cows from COVID was estimated to be about 2%. So that's probably not going to move the field to develop a vaccine for cows. However, this last outbreak in California, the mortality rate in the cows was 15%. So if this continues like this, maybe cows should be vaccinated. And sure enough, the first trial of a COVID vaccine for cows has started. And we'll see what happens. But right now, that's just it's still in the experimental phase.
Mhm. And that is the avian flu vaccine for
Avian
cows.
flu vaccine. Avian
Yes.
flu vaccine for cows. That's right.
Also, a quick update regarding that mysterious Missouri case. We still don't have the sequencing data released on the other people around them. And also to clarify, that person had significant comorbidities and were hospitalized for those, and then subsequently was found to have the avian
Right.
flu. So when we previously talked about that person being in the hospital, it was actually not from the avian flu. So very important to note there.
Yeah, no, well, the avian flu could have contributed, but that person had underlying diseases and was otherwise sick, and they sort of got diagnosed that way. So
Mhm. Just glad we know the actual numbers. Hopefully, we'll get that other data soon.
yeah.
But moving on to our final story for today, we have Mpox. There was another approval for the Jynneos Mpox vaccine. Can you tell us about that approval and also the state of the outbreaks in the African continent?
Well, the outbreak is that there's some 31,000 suspected cases and 844 deaths. Mostly in the Democratic Republic of the Congo, but 17 other countries, including Zimbabwe, have reported cases. WHO has announced that they approved the company called Bavarian Nordic, their Mpox vaccine for adolescents aged 12 to 17, because this is occurring in kids. A lot of kids are getting Mpox. And so that's a good thing. The vaccines have initiated the delivery into the country, importation into the country, and delivery at clinical sites, and they've started vaccinating people. So this is great news. And there's also going to be another study in kids 2 to 12 years of age, because they can get very debilitated and you can die from this, as I just mentioned, especially these young kids. And that whole process of getting enough vaccines over there to vaccinate the 10 million people that need it is ongoing. So
Mhm. We will keep you all updated on the status of that outbreak and others. But on that note, I'd like to thank you, Dr. Murphy, for your time and your expertise, answering our viewers' submitted questions, as well as breaking down the latest headlines and research. It's much appreciated.
well, thank you, Katie, for putting all this together.
And thank you all for joining us for another episode of the Ask Dr. Murphy series. We hope to see you again next week. And of course, if you have any questions or suggested topics that you would like to see discussed on the show, please send them to any of our social media, including email, Facebook, down in the description. We'll see you next week.